today very interesting lecture in Oman Society of Nephrology and Transplantation scientific program about diabetic kidney disease. Our speaker, Dr. Hayam, acting consultant nephrology in Khoulah Hospital. And she is very interesting in systemic nephrology. And today we will know more about diabetic kidney disease. Thank you, Dr. Hayam, and you can start, inshallah.
Thank you, Dr. Ahmed. Good evening, everyone. And thank you very much for giving me the chance to present today in this wonderful society. So today I'm going to speak about diabetic kidney disease. I'll give you some updates. So this is my outline. So I'll start with a case. Mr. TK has been referred by his GP for advice about ACR. He is 52-year-old Omani male with CKD stage 3B, A3, and the setting of type 2 DM, hypertension, coronary artery disease, dyslipidemia. He is currently on nifedipine, atorva, and metformin. His BP is 140/80 with heart rate of 80. His most recent labs showed eGFR of 34 as compared with 37 in the past, urine ACR 350 milligram per gram, and A1C 7.8%. And as you know, diabetes is the leading cause of CKD worldwide, followed by hypertension. And diabetes keep increasing with time and expected to jump 55% by 2035. And I want to highlight a very important prognostic factor in DKD, which is urine ACR. Urine ACR sometimes is underutilized by some physicians. And patient, when counseled about CKD, they counsel them only about eGFR, not urine ACR, while only urine ACR can give you really indication of the risk of progression to end-stage kidney disease. So it is like independent risk factor. As you see in this slide, if you got patient with A3, severe albuminuria, urine ACR more than 300 milligram per gram, this patient will have a high risk to very high risk for progression to end-stage kidney disease, regardless of the eGFR. And if you got patient with A2, moderate increase in albuminuria, 30 to 300 milligram per gram, patient will have moderate to very high risk of progression to end-stage kidney disease. So it's very important to communicate with your patient about urine ACR and eGFR also. So as you know, diabetic kidney disease is a very complex disease. It has many phenotypes, and sometimes it's unexpected to predict the prognosis. So some patients will have the classical DKD, they will have a progression in their proteinuria or albuminuria, and then they will have a progression in their CKD. Some of the patients, they will have regression of albuminuria. Some of the patients are rapid decliner, and we have some patients who got mild albuminuria, but they have rapid progression as well of CKD. So it's really unpredictable. And usually the type 2 DM patient, they will have dilated efferent arteriole in their glomerular, and they will have constricted efferent arteriole, and this will increase the intraglomerular pressure and will lead to increase in the albuminuria. So with RAS inhibitors that will work on the efferent arteriole, that will lead to decrease the constriction and will vasodilate the efferent arteriole. So that will lead to a decrease in the intraglomerular pressure and then a decrease to the albuminuria. So we have many RCT trials that has been done on the ARBs and DKD patients. The landmark trials of ARBs and DKD, the IDENT trial and RENAL trial. IDENT trial is like RCT trial that has compared irbesartan with amlodipine and with the placebo, and the composite endpoint was doubling of serum creatinine, onset of end-stage kidney disease, and death from any cause. So an IDENT trial has shown that there was a significant drop in the endpoint in irbesartan group as compared with amlodipine and placebo. And the GFR decline was lower, 5.5 versus 6.5 ml per minute per year in placebo group. And the renal trial is again another RCT trial, which compared losartan with the placebo, and the endpoint was in the stage renal disease or doubling serum creatinine, and again showed there is a difference, significant difference between losartan and placebo. There is a drop in the endpoint with the losartan group, and the GFR decline estimated to be 4.4 versus 5.2 in the placebo group. There are other trials like IRMA2 trial, which also has been done in type 2 DM with moderately increased albuminuria, and showed there is a dose-dependent reduction in the risk of progression of CKD, as well in innovation trial has shown the same, that there is a lower transition rate to the overt nephropathy with treatment with telmisartan. So in KDIGO guideline 2022 has recommended to initiate any patient with diabetes, hypertension, and albuminuria with ACE or ARB, and to be titrated to the highest approved dose that is tolerated. And also this recommendation is available in KDIGO BB, blood pressure in 2021, and for patients with type 2 DM stage 1 to 4 CKD and with moderate to severe albuminuria. There was also a STOP ACE trial, which is randomized controlled trial to address continuation versus stopping ACE or ARB in stage 4 to 5 CKD and included diabetic patients. There was no difference in the eGFR at 3 years between the continuation or the discontinuation groups, and the rates of initiation of renal replacement therapy and adverse events were similar between groups, although the number of cardiovascular events was higher in the discontinuation group. So this is schedule showing the starting dose and the maximum daily dose for ACE or ARB inhibitors. For example, in lisinopril, the starting dose should be 10 mg OD for the normal eGFR, and the maximum should be 40 mg, of course, if patient tolerated that dose. And you need to decrease the dose to 50% if patient has creatinine clearance from 10 to 30, and to reduce the initial dose to 2.5 if patient got creatinine clearance of less than 10 ml per minute. Another standard of care is the target of A1C. Before, the target of A1C was below 7%. Now there is a range between less than 6.5 to less than 8%. And that depends on many factors. It depends on the severity of CKD, macrovascular complications, comorbidities of patient life expectancy. So if and risk of hypoglycemia. So if patients got high risk of these factors, your target should be less than 8%, while if patient got lower risk, you should target less than 6.5. So it's a range, not one number. So again, in the landmark trial, as you see that, yes, there is reduction in the endpoint. There is a benefit for the onset of end-stage kidney disease. There is a delay. However, there is a progression over time of CKD even for patients who are on ARBs. So new medications came. SGLT2 inhibitors, which are anti-hyperglycemic class of medications that has been approved by FDA. And this medications has novel mechanism. It function through blocking the SGLT2 channel in the proximal tubule, so it will prevent the glucose and sodium reabsorption, and that will lead to the increase the glucose excretion in the urine, and will reduce the insulin resistance and improve the weight and the obesity. In addition to that, as you know, that because the diabetic nephropathy patient will have afferent dilated and afferent vasoconstricted, so this medication will work on the afferent arteriole, so it will reduce the vasodilatation, so it will cause vasoconstriction, and that will decrease the intraglomerular pressure, so will lead that to the decrease in the albuminuria. So we have many trials on SGLT2 inhibitors. I will discuss only two trials here. We have a Credence trial, which has been done on a patient with type 2 TM, and those patients got a severe albuminuria from 300 milligram per gram to 5,000, and the eGFR was from 25 to less than 90 ml per minute. Those patients were randomized to canagliflozin 100 milligram or placebo. And the primary outcome was doubling of serum creatinine, onset of end-stage kidney disease, death due to cardiovascular or kidney disease. And this study, the primary outcome was the risk ratio was 30% lower in the canagliflozin, and the end-stage kidney disease was 32%. The risk ratio or risk reduction ratio was lower by 32% in the end-stage kidney disease. So on top of that, there is no increased risk of amputations or fractures, and that will lead to a conclusion that type 2 patients with proteinuric DKD will benefit from canagliflozin, and also in terms of the kidney failure and in terms of the cardiovascular. As you see here in this graph, there is a significant reduction in the urine ACR in the canagliflozin group as compared with the placebo. And in this graph showing the change of eGFR from baseline, as you see in the slide, there is a drop in the eGFR estimated to be 3.7 in 3 weeks. And this drop, not surprising, it's really corresponding to the mechanism of action of canagliflozin, which is like decreasing the intraglomerular pressure. But at the long term, there is a crossover between the two groups, and then there is a decline or a slow decline in the eGFR for the canagliflozin as compared with the placebo. So for the canagliflozin group, is estimated to be the drop of the eGFR 1.85 ml per minute per year. and as compared with the placebo, 4.59, and the difference is around 2.74. Another trial called DABA-CKD. This is again RCT trial, which has been done in CKD patients. 2/3 of those CKD patients were type 2 DM, and the eGFR was ranging from 25 to 75 ml per minute, and the urine ACR was from 200 to 5,000 milligram per gram. Those patients were randomized to placebo versus dapagliflozin 10 mg OD, and the composite. Hello? دكتور العمري.
Hello?
دكتور العمري.
I'm
Can you, yeah, your microphone. Can you mute your microphone, please?
Yes.
Thank you.
كملي انا قفلت عليهم.
Okay, thank you. So, and the composite outcome was the decline in the eGFR, at least 50%, in the stage kidney disease, death from renal causes. And this study has showed really a statistical significant drop in the endpoint with the dapagliflozin group as compared with the placebo. And in the composite kidney outcome, in the cardiovascular outcome, and in the death from any cause, and the conclusion that this dapagliflozin has really a kidney and cardiovascular protection in the DKD patients. So this is slide showing the same. Regarding the adverse events, there was no statistical significant difference between amputation in the amputation and fracture between both groups. Regarding the volume depletion was more in the dapagliflozin group, and the p-value was 0.01. So back to case 1. So our answer for the GB, yes, you can start ACE or ARB because this patient is a very high risk of progression to end-stage kidney disease, given that he has severe albuminuria with a urine ACR of 350 milligram. And you need to increase or titrate up the dose of ACE or ARB gradually till you reach the maximum tolerated dose. So patient need to come to the clinic maybe in 1 or 2 weeks just to check for potassium, eGFR, and blood pressure, hypotension. And if patient is still having severe albumin or moderate to severe albuminuria, although on the maximum tolerated dose of ACE or ARB, patient better to be on SGLT2 inhibitor. So this is in the KDIGO guideline now. The new standard of care, SGLT2 inhibitor, is the first-line drug therapy with a RAS blocker on top of statin and metformin. And here's some tips for the nephrologist who's going to start SGLT2 inhibitor. The eligible patient should be more than or equal 20 ml per minute eGFR. That because of the trial that for empagliflozin, the eGFR was from 20. So the high priority features, the ACR was more than or equal 200 milligram per gram, heart failure, and potential contraindications like genital risk, infection risk, the DKA, foot ulcer, immunosuppression to consider when you start patient. And of course, the proven medications for DKD are 3 medications: canagliflozin, dapagliflozin, and empagliflozin. And you need to educate patient about sick day protocol, perioperative care, and food care. This slide showing the same, that SGLT2 inhibitor should be more than or equal to 20. And we have, I will talk about the second line later. So for the same patient, sorry, there should be a case before that. Okay, so for example, let's say if the patient still was on 2 medications, on ACE or ARB and SGLT2 inhibitors, and you cannot titrate up the ACE or ARB more, and you reach the maximum dose, and patient is still albuminuric, getting moderate to severe albuminuria, there is a second line medication or add-on therapy. It's a new medication. It's non-steroidal MRA, finerenone. So what is finerenone? It's like a non-steroidal MRA, and it's a mineral corticoid receptor blocker, and also it has anti-inflammatory and anti-fibrotic mechanism. So for finerenone, we have two trial, Fidelio trial. Fidelio trial, this is RCT, double-blinded trial that has been done in the proteinuric type 2 or DKD patients who were on the maximum tolerated dose of RAS or ACE or ARB. So these patients randomized to receive finerenone plus placebo, and the primary composite outcome was kidney failure, sustained decrease of more than or equal 40% in EGFR, death from renal causes. The secondary composite outcome was cardiovascular death, non-fatal MI and stroke, hospitalization for heart failure. So it has been found in this trial that there is 17.8% endpoint in the finerenone group as compared with 21.1%, which is statistically significant. And the secondary outcome is lower in the finerenone group as compared with the placebo. And the conclusion will be that finerenone really can give CKD, kidney protection and cardiovascular protection in DKD with significant albuminuria. So this graph showing that the urine ACR is lower in the finerenone as compared with a placebo group. There is another trial called Figaro DKD trial. This is another RCT trial, double-blinded, which was done again in type 2 DM patients who are albuminuric, and they are on the maximum tolerated dose of ACE or ARB. Primary composite outcome here, the cardiovascular death, non-fatal MI, and hospitalization for heart failure. The key secondary composite outcome was kidney failure, sustained decrease of more than or equal 40% in EGFR, death from renal causes. And this trial showing that there is really a significant drop in the primary outcome in the finerenone group as compared with placebo, but there was no statistical difference in the secondary outcome. Also, there was a higher discontinuation of trial due to hyperkalemia in the finerenone group. It was 1.2% versus 0.4% in the placebo. Also, in the Fidelio trial was higher discontinuation due to hyperkalemia. So finerenone received FDA approval in July 2021 for use to reduce the risk of kidney function decline, kidney failure, cardiovascular death, non-fatal heart attacks, and hospitalization of heart failure in adults with chronic kidney disease with type 2 DM. And there is a suggestion in KDIGO DKD guideline for the non-steroidal antagonist with a proven kidney or cardiovascular benefit for eGFR more than or equal 25 ml per minute and albuminuria more than or equal 30 milligram per gram, despite maximum tolerated dose of RAS inhibitor. This is some practice point that you can use this medication if patient got the maximum RAS or and SGLT2 and albuminuria is significant. So this case should be before, but this patient briefly is on the SGLT2 and ARB, and the ACR is 2,238, so he has a very high risk for progression to end-stage kidney disease. So we can consider this medication if available for this patient, given that the potassium is normal. So potassium should be normal because this medication can worsen the hyperkalemia. So I need to tell you the case. So Mr. MK is 65-year-old Omani male with presumptive diabetic kidney disease with a stage G3BA3 in the setting of insulin-treated type 2 DM with diabetic retinopathy and neuropathy, hypertension, diastolic heart dysfunction, morbid obesity. His average blood pressure is 120/70 with pulse rate of 69 beats per minute. His current eGFR is 40 ml per minute and serum potassium is normal, 4.8. His urine ACR is 2,238 and his A1C is 7%. He is on maximum dose of ARB, calcium channel blocker, beta blocker, a loop diuretic, and SGLT2 inhibitor. So Mr. MK came to the CKD clinic for follow-up after 1 year, noted his potassium 5.8, eGFR around 40, A1C 8.5, blood pressure 126/70 with heart rate of 75. He is currently on same medication. Finerenone was not added, only SGLT2 plus ACE. So now I'm going to speak briefly about RAS inhibition and management of hyperkalemia. As you know, patients with a normal eGFR rarely to get hyperkalemia, and we should not see hyperkalemia unless patients reach eGFR around 15 to 20. But we, in the CKD patient, we see it more often because of the medications. So any blockage in the RAS system can cause hyperkalemia earlier. So given that this complications quite common in our CKD clinic, especially in CKD 4 and 5 advanced CKD, so there are a few treatment options for chronic hyperkalemia with limitations. So regarding the first option, we have the dietary potassium restriction of 50 to 75 milli equivalent per day. Patient may already have other restricted diets, like patient always be in counsel to be on low phosphate, low salt diet. So it may add extra burden on the patient, and that will lead to consumption of less healthy foods, less fresh fruits and vegetables, and compliance is low most of the time. Other option we got is non-potassium sparing diuretics. And of course, efficacy will depend on the residual kidney function, and the hypokalemic response to diuretic will be reduced with low eGFR and will be dependent on the type of diuretic. Higher doses, of course, will limit up the titration of ACE or ARB, likely because of AKI, volume contraction, or electrolyte abnormalities. Another option, we have sodium bicarb. It's recommended when metabolic acidosis is the cause of hyperkalemia,
should not be administered to hypervolemic patients, or we should be careful due to the risk of pulmonary edema. Traditional potassium binders, calcium polystyrene, and sodium, it is not well tolerated due to GI side effects. Usually patients will not continue to take it, and there is a risk of hypokalemia, and we should be careful with the sodium formula because of the high risk of pulmonary edema. And in some cases, or very rare cases, use can be associated with life-threatening side effects like intestinal necrosis. And of course, the last option that we can have is to reduce the RAS or MRA, or to stop completely, but that will increase the morbidity and mortality, and you will deprive the patient from the kidney and cardiovascular protection. So I just want to highlight this point, very important point, that traditional potassium binders should only be used in emergencies and avoided for managing non-emergent hyperkalemia, like the one associated with ACE or ARB or MRA. So for chronic hyperkalemia, you should avoid the traditional potassium binders. So KDIGO guidelines has endorsed new potassium binders from 2020. In the latest guideline, if you initiate ACE or ARB and you found that patient got hyperkalemia, of course you need to review the medications, the other medications. You need to moderate the potassium intake, although it's difficult. You consider diuretics, sodium bicarb, and potassium binders. And here they mean the new potassium binders. And if you didn't succeed or if the medications not available in your center, so you need to reduce or stop ACE or ARB completely. So here a comparison between the traditional potassium binder, Patromer, and the new binders, the Patromer and sodium zirconium. So the mechanism of action for the sodium polystyrene sulfonate, it is sodium potassium exchange resonium, often given with sorbitol, and it is non-selectively binds potassium, calcium, magnesium. Time of onset is variable from hours to days, and binding site is in the colon, and common side effect, as I mentioned, it's a diarrhea, GI side effect, metabolic alkalosis, hypernatremia, volume overload, if it is the sodium formula. The Patromer is another resonium, exchanges the calcium for potassium, and also it binds magnesium. Time of onset is 7 hours, and binding site would be the colon. Also, this medication has GI side effects like constipation, diarrhea, abdominal pain, hypomagnesemia, and you need to separate the dose from other oral drugs by at least 3 hours. The third one is the sodium zirconium. It's resonium that binds the potassium in exchange for hydrogen and sodium, and the time of onset 1 hour. It's very fast. The action is very fast, and the binding site is the entire intestinal tract. The side effects is GI side effects like constipation, diarrhea, and edema. So I will talk very briefly about the MFSTN trial. It's a trial that has been done in multiple or many centers in Europe. They randomized the hyperkalemic patients, randomized patients who got diabetes and
ACE or ARB and developed hyperkalemia. Two groups we have: mild hyperkalemia of more than 5 to 5.5, moderate hyperkalemia more than 5.5 to less than 6. So the mild hyperkalemia patient group has randomized to 4.2 to 12.6 gram patromer BID. Moderate hyperkalemia has received from 8.4 to 16.8 gram patromer BID, and the endpoint here is
the change of potassium from the baseline. So at week 4 and throughout till week 52.
Dr. Hayam, sound is not clear.
Sorry?
The sound cannot clear.
Okay.
خلاص
Do
now
you
okay.
Now okay? Okay. Do you want me to repeat this slide, the explanation in this slide? Hello? Hello?
اتفضلي كملي.
Yes, اتفضل.
Okay. Do you want me to repeat the explanation on this slide? Yes or no?
Yes, you can
Okay.
start.
Yes, you can
with the
repeat
slide.
it, please. Yeah.
Yeah, okay. So again, in this trial,
hyperkalemia was divided to mild hyperkalemia and moderate hyperkalemia. So the mild hyperkalemia group
where the patient who got potassium of more than 5 to 5.5
were randomized to receive from 4.2 to 12.6 gram patromer BID, and the moderate hyperkalemia group where the patient who got the potassium more than 5.5 to less than 6, also randomized to receive from 8.4 to 16.8 gram patromer BID. And the endpoint in this trial is to see or to assess the change of the potassium from the baseline. So here in this graph, the mean serum potassium in the mild hyperkalemia group was statistically significant, lower than the
Sound not
baseline. Sorry,
sound not clear.
again. Now,
بس أحيانا هيام صوتك يختفي وحنظهر very clear، فيمكن في شيء من ناحية البوزيشن ولا حاجة.
okay, now is it okay الحين تسمعون زين؟
الحين أوكي.
Okay. Okay. Because of the position. So, so for the mild hyperkalemia group, there was a statistical significant drop in the serum potassium as compared with the baseline, and also in the moderate to severe hyperkalemia group, there was also a significant drop. So here, the change in serum potassium for the mild hyperkalemia,
and for example, for patients who received 16.8 BID of patromer, got a drop of 0.5 in 4 weeks, which is really good. And for patients who received 25.2 in the moderate hyperkalemia, got around 0.9 a drop in the serum potassium from the baseline. This is also showing in the drop of potassium from baseline in week 8 as well. There is a significant drop in all groups. And the side effects that they found in this trial, most of the side effects were GI, like constipation, abdominal pain, diarrhea, and also patient got hypomagnesemia. Most of the hypomagnesemia was mild to moderate. That's why serum magnesium should be monitored for at least 1 month after initiation of treatment, and magnesium supplementation should be considered in patients who develop low serum magnesium levels. This is another trial, AMBER trial, also to assess the safety and efficacy of batromer to facilitate use of spironolactone in resistant hypertension and advanced CKD. So this is RCT trial. We got two groups. All patients should have resistant hypertension and should be on spironolactone. The first group will receive batromer. The second group will receive a placebo. So they found that the group that got batromer, they stayed on, or there was a persistent use of spironolactone of 84% as compared with 56% in the eGFR of 25 to less than 30, while in the subgroup of eGFR 30 to 45, also 86% as compared with 69% and was statistically significant. And the adverse events between the two groups were comparable. So this graph showing that in the placebo group, 55.9, batromer 84, same. So the p-value was 0.016. And in the other subgroup, also statistical significant. And that's showing that batromer facilitate also the use of spironolactone among patients with resistant hypertension. This is another trial, sodium zirconium. I will not go through the details of the trial, but it showed this trial has been done over 14 days for 2 weeks only. And patient has been randomized to receive zirconium versus a placebo. And there was a significant drop in the potassium in 48 hours only. So most of the patients reached normokalemia, normal potassium, and normokalemia has the effect has remained for the 14 days, for 2 weeks. So this is also a very promising anti-hyperkalemic medication that can be used for chronic hyperkalemia and also maybe can be used for acute hyperkalemia. And this is the last slide. Thank you very much. The end of my presentation.